All right, and I see that we've hit our noontime hour. We can get started here. We are welcoming today Dr. Fadi Chalhoub, who is going to be talking with us in just a few minutes about the heart's electrical system. But I just wanted to say happy Sunday to everybody and welcome to the Baystate Health Heart and Vascular Lecture Series. My name is Fadi Chalhoub, and I'm a clinical exercise physiologist here in cardiac rehab at Baystate Medical Center in Springfield, Massachusetts. I just want to take a moment again to thank Sue Fontaine, our senior coordinator for loyalty programs, and Andrew Pond today in media services for everything they've been doing behind the scenes to help with this series every week, which has been fantastic. If you're joining us live today, again, we will welcome questions that you have regarding the information that is going to be shared today. We'll address as many questions as possible at the end of the presentation. To ask a question, you can type it in. It's going to be, there's a section on the right-hand side of your screen that says Q&A, and you can type your question in there. And again, we just ask that you keep your questions pertinent to the topic today. And again, we'll address as many as possible at the end of the presentation. Finally, you will have an opportunity to provide comments and feedback about today's lecture, and that will be immediately following the presentation. You'll be prompted automatically for that. As a reminder, our presentation today and all of the presentations we've had for Heart Month have been recorded, and they're now available for viewing on the baystatehealth.org website. You can just click on the heart icon, and it's labeled under the Heart and Vascular Lecture Series. Okay, so at this time, I'd like to introduce Dr. Chalhoub. Dr. Fadi Chalhoub is a board-certified cardiac electrophysiologist here at Baystate Medical Center in Springfield, Massachusetts. He specializes in the electrical activity of the heart. Dr. Chalhoub gained his medical degree from the American University of Beirut, Faculty of Medicine in Beirut, Lebanon. He completed his residency at Tufts Medical Center in Boston, Mass., and his fellowship in cardiovascular disease at Mount Sinai School of Medicine in New York. He went on to further specialize, completing his postdoctoral fellowship in cardiac electrophysiology at Mass General Hospital in Boston. Thank you so much, Dr. Chalhoub, for being here today and taking the time to share this information with us. We really appreciate it.
Thank you so much. I just want to first thank the organizers of these wonderful lecture series. I want to thank Dr. Pat for inviting me, Dr. Kugelmas. I really want to thank Heidi, Patrick, Sue, and Andrew for tirelessly working. This is absolutely outstanding. Thank you guys for your work. And I'll be very excited to talk to you today about the heart's electrical system and treatments and different forms of them. Thank you so much, guys. So to start with, I'm going to discuss the heart's electrical conduction system. Again, my name is Fadi Chalhoub. I'm one of the cardiac electrophysiologists at Baystate Medical Center in Springfield, and I'm going to speak about the different arrhythmias and therapies. So first, I'm going to review the anatomy of the heart. So to start with, the heart is a muscle that pumps blood to the body. We have 4 chambers in the heart. We have the right upper chamber called the right atrium. This gets the deoxygenated blood from the body, pumps it to the right ventricle, which subsequently pumps it back to the lungs, where the blood gets oxygenated, and the oxygenated blood goes into the left atrium or left upper chamber, that goes into the left ventricle or left lower chamber, and subsequently gets pumped to the body. The heart's electrical system is an elaborate, complicated electrical wiring system within the heart that conducts electrical impulses so the heart muscle can contract. Electrical impulses start in the sinus node, which is located in the right upper chamber or right atrium. Electrical impulses then conduct down to the AV node, which is located at the intersection between the top and bottom chambers. Electrical impulses then go down into the bundle of His and the bundle branches, where they innervate the heart muscle and the heart muscle contracts. This is another schematic of what I was describing. Impulses start in the sinus node, travel down to the AV node, which is at the intersection between the top and the bottom chambers. From the AV node, electrical impulses travel down, the heart muscle contracts. Again, this is, so I'm going to talk about the different forms of arrhythmias. What are arrhythmias? Arrhythmias are abnormalities in heart rhythm. We have abnormal slow heart rhythms, or bradyarrhythmias, to be distinguished from bradycardia. Bradycardia means a slow heart rate, which could be normal or abnormal. These abnormal slow heart rhythms are as a result of diseased sinus node, AV node, or the bundle branches. Abnormal fast heart rhythms could also happen, or tachyarrhythmias. They could happen in the top chambers, and they are called atrial tachyarrhythmias, or in the bottom chambers, or ventricular tachyarrhythmias. So the atrial arrhythmias tend to be the benign ones. Ventricular arrhythmias are more malignant and tend to cause sudden death. So what causes bradyarrhythmias? As I discussed, any diseases in the sinus node, AV node, or the bundle branches tend to cause abnormally slow heartbeats. Why does that happen? Age is a good factor. The older we get, the more wear and tear on the wiring system we have. People who've had previous heart attacks tend to have diseased heart muscles and diseased conduction system that could result in slower heart rates. People with cardiomyopathies or weak hearts tend to also have diseased conduction system. People who have had cardiac surgery in the past also could have their conduction system be affected by the surgical operation. Finally, medications, infections, and other uncommon conditions could cause any diseased sinus node, AV node, or the bundle branches. What symptoms do we get? Typically, it starts with dizziness or lightheadedness, faint, feeling almost about to pass out, feeling fatigued and tired, and lastly, feeling very short of breath. People cannot go about their daily life without experiencing some fatigue and shortness of breath. How do we solve this? So we solve slow heart rates by putting in pacemakers. And what are pacemakers? Pacemakers are fully implantable devices that are implanted in the left shoulder. And we have two wires that go into the heart vessels, into the heart, one into the top chamber and one into the bottom chamber. So the system again comprises of a pulse generator. This is the brains behind the pacemaker. This is where the circuitry is, the battery is, and all the electronics are. And these two wires, I'm going to refer to them as leads. These are called leads. These travel from the vein underneath the collarbone. Two leads go into the heart. One goes into the top chamber to pace the top chamber, and one goes into the bottom chamber to pace the bottom chamber of the heart. Both leads or wires are attached to the pacemaker, after which the incision is closed and this is fully implanted. This is a small schematic of what the pacemaker is. So with the pacemaker, as you see here, sometimes it senses the normal, it's not going to deliver, and then subsequently when there's no heartbeat, the pacemaker is going to deliver a heartbeat and the heart is going to pace. So a brief history of pacing, this is interesting, and it steps into the American ingenuity and how we overall developed these pacemakers. So in the 30s and 40s, cardiac pacemakers were big devices that were placed right by the patient's bedside, and they used to plug it into the wall. And obviously, the patient can't walk; he's completely bedbound. He has electrical wires coming out of the pacemaker into the heart, and this was the case for years. Prior to that, they had developed the way to pace the heart from external devices. Up until October 31st of 1956, a huge blizzard hit Minneapolis, Minnesota, and 15 inches of snow hit in early October. This was pretty unusual for Minneapolis at the time. And we had a cardiac surgeon. His name was Walton Lillehei, and he was a cardiac surgeon that worked with pediatrics. And Earl Bakken was an electrical engineer who worked at the University of Minnesota. And he had started a small company called Medtronic at that time, which he used to fix some gizmos in his garage. And when the snowstorm hit, they lost power and 3 patients died, one of which was an infant, and this had made news. So when that infant died, because he was attached to that pacemaker, Walton Lillehei approaches Earl Bakken and asks him for a solution. Lo and behold, in his garage, he had developed the first pacemaker with a which was attached to the patient's chest, and which was attached to the patient's chest, and the fully and a mercury battery within this pacemaker, attached to the leads inside the patient's chest. This was subsequently published 2 years later. They had 66 patients, and they had published their discovery, and their patent was done at that point. Fast forward 2 years or 3 years later, you had 2 Swedish cardiac surgeons. One was Erik Senning, who worked with Walton Lillehei back in Minneapolis, goes back to Sweden and decides to internalize this pacemaker inside the patient's body. And he worked with Rune Almquist, another cardiac surgeon, and yes, they did use a shoe polish cover to create the first mold for their implantable pacemaker. That patient, his name was Arne Larsen, shown here. He was the first patient to have an implantable pacemaker in 1959. This patient had severe bradycardias and bradyarrhythmias. And after the pacemakers that he's had, he outlived both his surgeons to the age of 89 and had, over his lifetime, 22 pacemakers replaced. So these are the transvenous leads. These are the leads that go from the shoulder into the heart. Again, these leads, the older generation leads, were called passive fixation. These have tines, like fishing tines. They hook into the right ventricle and or the right atrium, and this is how we used to put the leads. Probably 2 decades ago, we started developing the active fixation leads, which represent a tiny screw that we deploy into the heart muscle. And this is a better way to fixate the leads into the heart muscle. This is the evolution of cardiac pacing over the years. In 1958 was the first pacemaker, and then fast forward, the technology has dramatically miniaturized. And now we have these devices not only are pacemakers, they also carry what we call diagnostics. They can detect any abnormal fast heartbeats as well in both the upper and bottom chamber. They monitor every single heartbeat a patient has, and keep quite a extensive diagnostics worksheet for them. 3-4 years ago, we had developed or now 5 years ago, we had developed the leadless pacemaker that was approved by the FDA in 2016. This leadless pacemaker has no leads. The pacemaker, the electronics, and everything is fully encapsulated in this bullet-shaped pacemaker, which is slightly larger than a pill. which implants into the patient's heart, into the bottom chamber of the heart. It has 4 tines that actively fix into the patient's heart. This is a small video on how we do this leadless cardiac pacemaker. Again, this is a bullet shot pacemaker with 4 tines. This is the delivery system. There's a needle, a guide wire, an introducer, which is a tube, and then this is the delivery system. On the top, there is a pacemaker, which we place into the patient's heart. Through a needle in the patient's groin, we introduce into the femoral vein. Into the femoral vein, we have a long wire that goes up into the major vessel, into the heart. This is the right upper chamber or the right atrium again. After that, the introducer is placed through the groin into the heart, taken up into the heart. The tube is then there, and we can place the delivery system within that sheath or introducer. The delivery system is then placed into the right lower chamber or right ventricle by traversing the valve. Under X-ray and contrast, we verify the apposition of the device on the patient's heart. The device is then deployed into the heart muscle. The tines tend to catch into the heart muscle. There's going to be a small schematic. I mean, there's no cameras in the device, but this is a cadaveric demonstration of how the device fixates into the heart with the 4 tines. We pull on the device, make sure it's in good position, that it's fully opposed with the heart. Make sure that at least 2 tines capture. Thereafter, with a computer, we check the device, make sure that all the numbers are working well. When everyone is happy, then the tether is cut and pulled. Once the tether is pulled, the device is fully deployed, everything is taken out, and the pacemaker is within the patient's right lower chamber. This pacemaker serves only to pace the right lower chamber. We are in the works for having a pacemaker for the right upper chamber that communicate with each other, so that it's completely internalized. So therefore, any patient who requires pacing in the right upper chamber as well is not a candidate for this micro-leadless pacemaker. To talk about tachyarrhythmias or fast heart rates, we have a lot of them. I cannot and do not have the time to go over these. However, I'm going to spend some time on 2 main things: atrial fibrillation and ventricular fibrillation. Atrial fibrillation occurs in the top chambers of the heart. Ventricular fibrillation is the more malignant one, happens in the bottom chamber of the heart, and leads to sudden cardiac death. Atrial fibrillation is by far the most common type of arrhythmia we encounter. And it affects the upper chambers of the heart. What tends to happen is the upper chambers tend to beat rapidly and frequently, and this leads the bottom chambers to beat rapidly and frequently. Atrial fibrillation affected 5.5 million Americans in 2019. Now we're close to 7 to 8 million Americans because of all the fancy ways that we're diagnosing atrial fibrillation with the iWatches and all the gadgets that we have. 1 in 4 adults over the age of 40 are at risk for having atrial fibrillation, or called AFib or AF. What is AFib? This diagram again is going to try to describe as much as possible what AFib is. In a normal heartbeat, the impulses again start in the sinus node in the right upper chamber. They're conducted down into the AV node. From the AV node, they pass to the lower chamber where the lower chamber conducts. During atrial fibrillation, you have signals that start in the left upper chamber, specifically in the pulmonary veins that connect the lungs into the heart. Everybody has those veins. These signals tend to compete with the sinus node. They shut it down and they take over. Once they take over, conduction proceeds down the AV node very fast. As you see during atrial fibrillation, the heart rate is very fast and irregular. during normal rhythm, it is slow and regular. I just wanted to mention briefly about atrial flutter. I know that a lot of patients have atrial flutter, and I may get that question. Atrial flutter and atrial fibrillation are virtually one and the same. They're cousins, they're sisters. The only subtle difference between atrial fibrillation and atrial flutter is the atrial fibrillation in the top chambers is very disorganized. These beats are very chaotic, very fast and disorganized. With a flutter, these beats tend to be more organized in a circular fashion. Both of them result in activating the heart in a very fast way. So the different types of AFib. This slide is very important. People tend to develop the first episode of AFib, and within 19 to 20 months, they tend to develop recurrent AFib. What a recurrent AFib is, different episodes of AFib, and this is called paroxysmal atrial fibrillation, which is the AFib that occurs and ceases within 7 days of onset. So the bout happens, and then after that, after a few hours, maybe a few days, the normal sinus rhythm takes over. This is called paroxysmal AFib, which tends to progress to persistent AFib over time. These episodes of AFib tend to become more frequent and last longer. Once they become more frequent and last longer, people tend to be in persistent atrial fibrillation when the atrial fibrillation now lasts more than 7 days at a time. If this is left untreated, atrial fibrillation then goes into long-standing persistent atrial fibrillation, which is atrial fibrillation that is persistent for more than 1 year. And if left untreated, people are in atrial fibrillation all the time, every day of the week, 24 hours a day, 7 days a week. Now, who is at risk for AFib? So we have the non-modifiable risk factors. This we cannot change, age. The older we get, the more at risk for AFib we are. Individuals after the age of 60 are 2.5% of the individuals after the age of 60 have AFib. I'm sorry about that. 10% above the age of 70, 1 in 3 to 1 in 4 people above the age of 80 tend to have AFib. Family history, this tends to run in families. Nowadays, we're detecting genes for AFib, but this is more or less for the younger individuals where this is not yet mainstream, or we are not testing it in the clinic as of yet. People with heart disease are at risk for having atrial fibrillation. Something I did not mention as well is people with big heart masses tend to have AFib. So on a side note, taller people tend to have AFib. So this is kind of a disadvantage to being tall, I guess. Then the other thing, if you translate it into the animal kingdom, for instance, whales and elephants are always in AFib. Mice and rats, it's impossible to induce AFib. Whereas humans and horses have, some of them are in AFib and others aren't, depending on where they fall. The more important thing with AFib is lifestyle, and lifestyle is heavily influencing AFib. And this arrhythmia is more of an arrhythmia of lifestyle than anything else. And the main thing with lifestyle is sleep apnea. People who snore at night are at risk for having AFib. During the night, when the oxygen level dips in people with sleep apnea, this causes a lot of stress on the heart, which increases the incidence of having AFib. Obesity is another big one. So nowadays we're seeing more and more because of the obesity epidemic, and people with obesity tend to have a lot of fat around their heart, which tends to cause a lot of inflammation and start AFib. Alcohol consumption and AFib go hand in hand. The more alcohol people consume, the more AFib they're going to get. And this has been shown in study after study. These risk factors now are less so: smoking, caffeine, and stress. These are less so correlated with AFib. Something to mention, though, is stress relieving maneuvers have, like yoga and all that, have been shown to decrease overall the incidence of atrial fibrillation. This is the map of the world, and this is the prevalence of AFib in the world. In North America and the United States, we tend to diagnose way more AFib than anywhere else in the world, if you can see that. Yes, we do have the tools to diagnose it. We have the advanced healthcare to diagnose it. But countries like Australia, Japan, and Europe also have some advanced healthcare system to diagnose atrial fibrillation, and they don't see as much AFib we see. And probably this is because of, yes, you guessed, our lifestyle. And with this lifestyle, invading different countries, probably they are going to see much more AFib later on. And with the obesity epidemic, this has definitely increased the numbers of AFib that we are seeing overall. And treatment of obesity is going to be paramount in managing of atrial fibrillation. Alcohol consumption. This was a very elegant study in January of 2020, published in the New England Journal of Medicine. This showed that abstinence from alcohol decreases overall the incidence of atrial fibrillation. And this is very, very important. It's 6 months of absence of alcohol, it decreases overall the amount of atrial fibrillation. Now, I have patients who ask me, if I stop alcohol, is the AFib going to go away? Probably not. But the amount of AFib the patient is going to have, the burden of the AFib is going to be very different. So what are symptoms in AFib? To start with, 40% of patients with AFib don't have any symptoms. The other symptoms from AFib could be the typical palpitations. Oh, my heart is, racing. I have very racy heart. I don't feel well. I feel my pulse in my neck and all this, and I feel it very fast. Other less symptoms or subtle symptoms from atrial fibrillation could be fatigue, shortness of breath, people who don't feel well overall. It may cause some very non-specific symptoms. And let me dwell on anxiety a bit, because you have a lot of patients that complain of anxiety. I feel anxious. And as a matter of fact, this could be correlated to episodes of atrial fibrillation, where the AFib can cause this anxiety sensation that could worsen AFib, that could induce anxiety and worsen AFib, and it becomes kind of a vicious cycle. Why is AFib important? Because AFib increases the risk of a stroke. AFib is not going to impact the life longevity. No, it's not. People with AFib or normal rhythm are going to live the same amount, the same life longevity they're going to have. But the quality of life is not going to be the same. The reason is because AFib increases the stroke by 5-fold. Also, 30% of strokes are caused by AFib, and the strokes from AFib tend to be the big ones, tend to be the fatal strokes, the one that lead people into nursing homes. So this is kind of the strokes which are related to AFib. Now, why does that happen? I'm going to discuss 2 complications about AFib. It's because of blood clots forming inside the heart. During atrial fibrillation, the heart is very irregular. The top chambers are very irregular. They're not contracting. I want you to focus on the left atrial appendage. Everyone has a left atrial appendage. This is located in the left upper chamber. It's a pouch-like structure in the left upper chamber. Once atrial fibrillation happens, this is going to increase the risk of blood clots to happen. The reason behind that is stasis happens within the left atrial appendage because it's not moving well. Once the blood is not moving well, this causes blood clots, which tend to dislodge from the heart and travel up into the brain and cause a big stroke. In addition, atrial fibrillation increases our risk for congestive heart failure. During AFib, as I mentioned earlier, the sinus node is shut down. The heart is going very, very fast. It's as if the heart is running a marathon 24 hours a day, 7 days a week. Eventually, it will weaken. Weakening of the heart muscle would result in congestive heart failure. Let me mention that is once AFib is treated in people with congestive heart failure and AFib, typically the heart function reverts back to normal. Now, not everybody with atrial fibrillation is at the same risk for having a stroke. So we try to measure what the risk of having a stroke is in a certain individual when we start a patient on a blood thinner for atrial fibrillation, which I will go on later. And the way we do that is we develop a risk score. So the sicker the patients are, the older they are, the more at risk for AFib. For instance, if we have a 50-year-old gentleman with atrial fibrillation, he doesn't fit any of these criteria. So let's say he has no high blood pressure or diabetes or anything. then his risk of AFib, of having a stroke, is what the average risk of having, what the average risk of of having a stroke is without AFib. However, if you have a 90-year-old lady with diabetes and high blood pressure, she has, if you add that score, she has high blood pressure, that's 1, diabetes, that's 2, she's above 75, so that's 2, so that's 4, and she's a female, that's 5. That puts her at a 6.7% risk per year if untreated. What are the signs for a stroke? These cause sudden numbness or weakness in the arm or face, causes confusion, trouble seeing in one or both eyes, sudden headaches, loss of coordination. All these could be signs of and symptoms of a stroke. Treatment options for AFib. So first and foremost, the thing we do with AFib is prevention of a stroke. And we measure what the patient's risk of having a stroke is depending on that score, which I mentioned, the Transvenous score, and then accordingly prescribe a blood thinner or discuss different options with them. Now, how do we treat AFib as an arrhythmia per se? First option is through cardioversion, and then medications, and then a catheter ablation, which I will go into detail. What is a cardioversion? A cardioversion is a controlled low-dose shock to the heart to convert the abnormal rhythm to sinus rhythm. And this is performed with anesthesia in the hospital and requires always, no matter what the Transvenous score is, a blood thinner to be on board. So the cardioversion is not going to do anything to change the properties of the heart for AFib. It's not going to change the milieu. So therefore, there are high rates of recurrence for atrial fibrillation. The cardioversion is basically a reset button. You just reset the heart from AFib back into normal. It's not going to change anything within the heart to prevent it from going into atrial fibrillation again. This is the cardioversion. We attach patches to the patient's chest that are subsequently attached to an external defibrillator. And we monitor the heartbeat. This is fast and irregular, which is atrial fibrillation. We deliver a controlled shock under anesthesia. And then basically the heart restores normal rhythm thereafter, and the patient is discharged home. The medications for atrial fibrillation that we have are called anti-arrhythmic medications. And these aim to restore or maintain normal rhythm. These tend to change the properties within the heart to prevent or terminate episodes of atrial fibrillation should they happen. Also, blood thinners are the mainstay, again, for high-risk individuals with atrial fibrillation to have a stroke. Antiarrhythmic medications, however, if patients decide to proceed with medications to treat atrial fibrillation, it more likely than not is going to be, because of the progressive nature of atrial fibrillation, medications tend to be a long-term, if not a lifelong option. And with time, medications become ineffective. And as a matter of fact, is over time, 50% of patients tend to have recurrences of atrial fibrillation despite being on antiarrhythmic medications. So they're not the best option. Which is a segue into catheter ablation. What is catheter ablation? Is a procedure to restore normal conduction of the heart back into its normal. And what is a catheter? A catheter is a long electrical wire that is placed through a small tube that we place into the heart, and then we navigate it into the heart. We cross from the right side of the heart to the left side of the heart. I'll show some diagrams, and we perform the catheter ablation. We use 3D technology to aid us to localize the catheter. Also, we use sometimes fluoroscopy, which is which is an X-ray, to visualize these catheters. And there are two modalities thus far for ablation, are radiofrequency, which is cautery, which is burning within the heart muscle, small burns, or cryo, which is freezing of the heart tissue. This is a catheter This is the tip of the catheter. This is the tip, which is 4 millimeter platinum, which is able to deliver cautery or radio frequency energy at the tip of the catheter. These catheters, we can navigate them in the heart. They can flex and anti-flex, and we can navigate them in the heart. These are diagnostic catheters, which help us create a map of the heart. Once we create that map of the heart, this makes it easy for us to do the ablation. This is the cryo ablation modality, where I will discuss about cryoablation at a later slide. This is the EP lab where we perform this procedure. We have an X-ray. This is an X-ray machine, which is there. This is a TV, which we have, a big TV, for X-ray and also to see the mapping system and the navigation on this. The patient's head, this patient is here, the feet are here, and this X-ray moves around the patient's head. Again, there's no big incision, no blades that we use. Everything is minimally invasive. And these are the catheters that we tend to use. What is the catheter ablation procedure? Again, this is what we do during the catheter ablation procedure. A catheter is moved from the patient's groin into the heart. We cross from the right side of the heart to the left side of the heart. Remember what I mentioned about AFib. It starts as triggers within the pulmonary veins, which everybody has those veins. In the olden days of doing this procedure, we used to chase those triggers. We used to try to burn them. What we found out is that there's a lot of them. It's not only 4 of them. This is only a diagram, but there's thousands of them. So instead of chasing them, what we do is we trap them. And the way we trap them is we cauterize in this circular fashion around the veins. So AFib is still happening inside, but not being transmitted outside. Now the sinus node takes over, causing normal conduction. This is the mapping system which I discussed, is during the ablation of the AFib. We shake the wand, create a nice map of the heart that would help us aid on where to go and chase those different signals. This is a rendering of the heart muscle. This is the map that we create. This is the catheter. It shows us the force, how much force we can apply so that we can know what we're applying good force. And these are the different lesions in a schematic way to show that we're going around the pulmonary veins. This is a different modality to do it called cryoballoon ablation. Similarly, from the groin, we go up into the heart. We cross from the right side of the heart to the left side of the heart where these pulmonary veins are located. The balloon is inflated with liquid nitrous, and this freezes the heart down to very, very low temperature, negative 30 degrees Fahrenheit. Once the heart freezes, the conduction is interrupted, and this is how we achieve the same result with this cryoballoon. The balloon is then moved from vein to vein to create that same result. Back to the slide, which is very, very important, I think, is the key here is to prevent progression of AFib. There's no cure for AFib. I wish there was a magic medicine that we take to cure AFib. I wish there was a magic procedure to get rid of AFib. And the reason is why AFib tends to happen after a catheter ablation procedure is 2 reasons. Is if I go back to my slide here, sorry about that, is with time, gaps tend to form within the ablation lesion set that we create. So after we create the lesion sets, what tends to happen is the AFib now sometimes tends to escape, and that's why people tend to develop AFib and require, again, recurrences. The second reason, which is fairly more common, is not all the triggers are located here. It's as the AFib becomes more persistent, these triggers tend to be located elsewhere. They migrate. They're now on the back wall of the heart. They're on the right side of the heart. They're like all over. And chasing them with ablation tends to be a cumbersome thing. And that's why the success of any treatment we do for persistent AFib tends to be lower than with paroxysmal AFib. With paroxysmal AFib, those triggers are only here. And that's why with the ablation procedure is very successful, up to 80%. But as AFib progresses into persistent, then the success rate for treatment becomes lower and lower. So it's important to stop it, if we have atrial fibrillation, to stop the progression into persistent. And if we have persistent AFib, to prevent it from progressing into long-standing persistent atrial fibrillation. And ultimately, what the goal is for the ablation procedure, in addition, is to reverse the course of atrial fibrillation, that people with long-standing persistent or persistent atrial fibrillation develop more paroxysmal atrial fibrillation, which is much more tolerated. So ultimately, in management of atrial fibrillation, there's no cure. It's going to be many things put together, medications, ablation, and also, which is very important, lifestyle modifications. And, I do tell my patients all the time, it's very important to get the sleep apnea treated, is to lose weight, is to stop alcohol, because all this is going to increase the success of having a durable result in normal rhythm. It's not the ablation alone, it's not medications alone, it's not lifestyle alone. It's probably, if we combine everything together, we would achieve a longer term success to prevent atrial fibrillation. Stroke prevention, I'm going to hint on. Again, blood thinners are very important. We calculate what the risk score is. If the risk score is more than 2, typically putting a patient's risk more than 1.5% per year, then a patient is prescribed a blood thinner. The other ways, for people who cannot tolerate blood thinners, we have a way to occlude the left atrial appendage, which is that small appendage where the blood clots form. And we can put a small sieve, if you want, to filter out the clots. Or completely occlude that device. Occlude that appendage. This is the Watchman device, which I'm going to mention briefly. What we do is, again, we cross from the right side into the left side of the heart. This is the big delivery sheath or tubes through which we put the Watchman device. Then we navigate this into the left atrial appendage. We inject some contrast initially to under X-ray to visualize this appendage, see how big it is. Subsequently, within the sheath, we put the Watchman device that is subsequently deployed into the heart. We make sure with a tuck test that it's not going to dislodge. We detach it from the delivery catheter. And then over the next 4 to 6 weeks, normal tissue would start to form over the Watchman device. And now the left atrial appendage is completely occluded. So AFib is a progressive disease. It's important to seek treatment as soon as possible to improve the quality of life. Probably by doing all treatments for AFib, we're not going to extend the patient's life because overall it's a benign arrhythmia from that perspective. But the quality of the life does get impacted. So we're controlling the arrhythmia and overall reducing the risk of having a stroke. So let me touch in briefly on ventricular fibrillation and sudden death. So arrhythmias of the top chamber of the heart typically are the more benign ones. An example of an atrial arrhythmia is atrial fibrillation, which I discussed. Ventricular arrhythmias, on the other hand, are malignant. What is ventricular fibrillation? This arrhythmia leads to sudden death. This is a normal heartbeat, sinus node, AV node, going down the conduction system. Suddenly, signals tend to happen in the lower chamber, take over, and basically the heart is unable to pump blood into the body. This rhythm appears. This is an alarming rhythm, obviously. This is a non-perfusing rhythm. And shortly thereafter, if this is not treated, this would ultimately lead into basically a complete cardiac standstill and sudden cardiac death. And who is at risk for sudden cardiac death? I mean, for many years, this was the holy grail for prevention of sudden death through the 70s and 80s and all this. And coming into the probably 1980s, medications were the only thing we had. And we tried a cocktail of medications to basically witchcraft our way to prevent sudden death. And we failed miserably at this. up until the era of 1980 when we had defibrillators, which I will discuss. But let me dwell initially on sudden cardiac death and who's at risk. So people who have had a heart attack. Any occlusion in the blood vessel causes scar tissue to happen in the lower chamber. Any scar tissue in the lower chamber creates this arrhythmia that would ultimately lead into sudden death. And this is the most common cause for death in the United States, way more than cancer or any other kind of death. Who else is at risk for sudden death? Is people with weak hearts. Is any people with a cardiomyopathy and a weak heart that is not able to function properly is at risk for sudden death. Typically speaking, people's heart function once dips down below 30%. What I mean by 30% is the blood which is ejected is the heart ejects only 30% of the blood that's in it. So that's the 30% number. That's called the ejection fraction. So once the ejection fraction dips below 30%, people are at risk for sudden death. And the lower the number, the higher the risk. Now, people above 40%, once the heart ejects more than 40% of the blood that's in it, those individuals are at a very low risk for sudden death. Finally, you have some other uncommon causes for sudden death in younger individuals, like hypertrophic cardiomyopathy, or other heritable disorders and other cardiomyopathies, which I'm not going to go through. This is way beyond the scope of this conversation now. But these account for, the minority of cases. The vast majority of cases for sudden death is coronary artery disease, which is an occlusion in the coronary arteries that would ultimately lead into scar tissue to happen into the heart. So this is the defibrillators. Again, for many years I was discussing, we're trying to prevent sudden death and find the right thing. Up until 1980, when an Israeli scientist by the name of Dr. Milowski wanted to save his mentor who had sudden death. And he came up initially with a prototype of a device that could happen, and tested it on dogs, and it worked. But none of the scientific community at that time adopted this. And it took a long time for people to adopt this. Now, what is a defibrillator? It's identical to a pacemaker as far as, it has a lead, a wire, and also a device. The device is bigger than the pacemaker. The footprint of this device is probably the size of a big diving watch. That's the size of this device. It's electronics and has a capacitor that's able to charge energy to deliver a high voltage shock into the heart. And the leads, also similar to the pacemaker, go into the heart. The procedure is identical to the pacemaker. Small incision in the shoulder, under the collarbone. We access the vein. We put in the wire or the lead again, and we attach it to the defibrillator under the skin. And this device is like an insurance policy. It's for people who have not had sudden death and with weak hearts, for instance, or previous heart attacks, we can prevent this. So these people tend to have defibrillators. The other form of defibrillator, which we've had now for almost a decade, is called a subcutaneous defibrillator. And this defibrillator does not go into the bloodstream or into the heart itself. The pulse generator is placed with an incision underneath the armpit. Right underneath the armpit, the device is slightly bigger. Completely, the lead or wire goes under the skin in this fashion and basically is attached. This is completely under the skin, over the chest cavity, over the ribs, over everything, over the muscles. And this device is under the skin and called subcutaneous defibrillator. The subcutaneous defibrillator and the more conventional defibrillator have been shown to be equivalent in many studies. Now, there are some advantages to having one versus the other. I'm not going to go through this now because it's going to add a lot to our discussion, and we're going down on time. I'm sorry about this. This is the implantable defibrillator. This is implanted completely under the skin. This is a schematic of what's this is the collarbone. And this is the first strip. Between the first strip and the collarbone, you have the vein. The leads go into the vein. The heart is detecting now, the device is detecting ventricular fibrillation here. The device is going to charge. And also, once the device charges, delivers a therapy, a shock between the device and the lead itself. And the normal sinus rhythm is then restored. This is one of my last slides, ladies and gentlemen. Thank you so much.
Wonderful. Thank you so much, Dr. Chalhoub. That was fantastic. We had this topic several years ago, and it seems like even in that time frame, so much has already changed with the science for AFib and the arrhythmias. So it's fantastic to see that so much is continuing to progress in this area of cardiac health. We have a few questions, and we can address them. As our participants, if you have additional questions, again, you can use that Q&A area on the right-hand side of your screen to type a question if you had anything for Dr. Chalhoub. One that came up is regarding COVID-19, which we addressed earlier in this series. And they're asking, are you seeing an increase in the arrhythmias in patients who have tested positive for AFib, or do we have any data about that?
That is interesting. We don't have the data as of yet. But what we have been seeing is not AFib, is more or less the heart block, is more or less slowing down of the heart. We, as I mentioned, some of the infections, including COVID, has been, we have seen this in some patients where their heart rates do slow down related to COVID-19. Thank you so much for this question, though. Mm-hmm. As far as atrial fibrillation, I am not aware yet of the data.
Great. Okay, thank you. I know that'll probably be coming out as time goes on.
Absolutely.
Here's a question about runners. Are long-term endurance runners more susceptible to developing AFib?
So whoever is asking that question is probably a runner. So what I do mention is yes, is there is some truth to that. The reason behind that is, remember the mass when I was discussing about the heart mass and the risk of AFib. So people with bigger heart masses tend to be at risk, and long-term endurance runners sometimes do have this increase in the heart mass, which tends to predispose them to have AFib. And that's why in some athletes, we tend to detect AFib specifically. So there is some truth to this, yes.
Great, thank you. Someone was asking, can you please comment on SVT? And is there lifestyle prevention that's best?
So again, I'm not going to go through all the arrhythmias. So if we are to go through all the arrhythmias, it's going to be a long topic. But I will hint. So SVT is another form of atrial arrhythmia. Remember the atrial and ventricular arrhythmias. The SVTs are curable with catheter ablation procedure. Typically, they don't happen. They're unlike atrial fibrillation, where there's no cure, as I said. But SVTs are curable because we understand fully the mechanism of where they happen, and they're more of one focus in the heart that we tend to cauterize and get rid of. So risk factors for SVT, like any arrhythmia, is going to be the same. Obesity, alcohol, and it's for all arrhythmias that that is one and the same. But SVTs also, people have the predisposition to have that. So sometimes some forms of SVT people are born with. They have like an extra electrical connection. Back to my first slide, I described the sinus node, the AV node, and the bundle branches. Some people are born with extra passages that connect the upper chamber, which cause SVTs, for instance. Other forms of SVTs are formed by different ways. So there is lifestyle to it, but also there's more or less genetics as well to SVT.
Great, thank you. A question from somebody who their father, it seems like they have valve surgery and AFib. First asking if that's two different things, but also I think you might touch into it. They're actually related sometimes.
Correct. So atrial fibrillation and heart surgery also happen together. So part of the risk factor for atrial fibrillation is cardiac surgery. Up to 40% of patients after cardiac surgery tend to develop atrial fibrillation. So I don't think that probably in this circumstance, if he had AFib after surgery, it's probably related. Now, that doesn't mean once the surgery is healed, the AFib is going to go away. We used to think that it's very common after cardiac surgery, but once they're out of that window, then the patient is fully healed. He's not going to have AFib. Probably that's not true. We know from the Framingham study, which we studied patients over a long time, that if AFib is secondary to something, like let's say patient had a binge of alcohol and he had an episode of AFib, or he had a severe infection in the hospital, which required him, put a lot of stress on the heart and he went into AFib. We know that all these secondary causes for AFib or primary AFib, which happens, out of no instigator, the rate of recurrence for both is the same over time. If that answers the question.
I think so. That's great. Thank you. Someone is asking, after leadless delivery, does the patient have to lay flat for 2 hours?
Yes. So because we go through the groin, we worry too much about the groins itself. So some people have closure devices where they can close the groin or whatnot. Then they can bed rest is faster. But I typically do 4 hours of bed rest after a leadless pacemaker.
Someone's asking about atrial runs. Is that the same as AFib?
That's a precursor to AFib. So atrial runs, if we monitor the hearts for a long period of time, we may have some extra heartbeats, some runs here and there in the heart, in the top chambers of the heart. Remember those triggers? So I was trying to describe with these triggers, the stars. These stars are the runs, if you want. And with time, this could ultimately lead to atrial fibrillation. However, they're not as, they're typically very, very benign.
Thank you. Question here, what are the risks of heavy weightlifting for an AFib patient who has had an ablation?
The risks of heavy weightlifting. It depends on how it's after the ablation. So after the ablation, I just highly encourage my patients to do whatever they can, right? Whatever they have. As far as weightlifting is concerned, what I would advocate to my patients is, if they want to go to the gym and whatnot, maybe more reps and lighter weights. That's kind of what I would advocate to most of my patients.
Here's a question about a family history in AFib. So if people have a family history of AFib and congestive heart disease, should they be screened for AFib? And if so,
that's a good question. That's a good question. As of yet, there's no guidelines for screening for AFib. There are no guidelines to screen people for AFib as of yet, which is a great question. Now, family history so AFib is as common as saying you have high blood pressure. And like high blood pressure, it's not like one gene that causes it. It's like it's like many genes, and it's also influenced by the lifestyle a lot. So for people with family history for AFib, they are at risk for having AFib, but that doesn't mean that they're going to have AFib. And as of yet, there are no guidelines to screen for atrial fibrillation.
This one here is about the bullet pacemakers or the leadless pacemakers. How often do they have to be changed?
So now we're accumulating more data. Initially, it depends on a lot of the values of the numbers that we get. They can be as long as 12 to 14 years. The reason why they're longer than the transvenous pacemakers is they don't carry a lot of the computer diagnostics that are there. They only pace the heart. So they're working as very basic pacemakers. The pacemakers that are in the shoulder, the conventional ones, are highly sophisticated computers. So with a lot of chips and a lot of diagnostics that run, and that's why they continuously monitor the heart, and therefore their battery life tends to be shorter than the leadless pacemaker, which is basically a smaller. Now, as far as replacement is concerned, we will know we know now that these devices are extractable, that we can extract them safely from a patient's heart. Now we're developing more data to see how to extract them. However, some people have said if you can place another pacemaker, if he needs another leadless pacemaker after 14 years, that can be placed at a different location than the first one.
Great. Thank you. This one is regarding defibrillators and pacemakers. Are there defibrillators that can also pace if I have?
All defibrillators pace. All defibrillators have all defibrillators have pacemakers in them. So they're a pacemaker plus a defibrillator in them. Correct. So they're all in one device. So those devices, I put them separate from each other because because my conversation was going in that direction, but all defibrillators provide pacing to the patient, should he need it.
Do all pacemakers defibrillate?
No, pacemakers do not defibrillate. Pacemakers, because defibrillators have capacitors that charge energy, that tend to, deliver the energy. Pacemakers do not have capacitors. So what they do is they just have a battery, which is a lithium-ion battery, similar to, the lithium-ion battery that they have. And also they have, computers. They don't charge capacitors to shock.
Great. I've got just a couple more questions for you. I know we're running into the 1 o'clock hour. This person had AFib for about 10 years. They were on diltiazem and baby aspirin. Could the diltiazem stop being effective eventually?
So diltiazem does not controls the heart rate in AFib. So whereas I was mentioning anti-arrhythmic medications, I don't lump diltiazem typically as part of the anti-arrhythmic medication. Diltiazem controls the heart rate during atrial. So people could be in atrial fibrillation. Diltiazem works on the AV node to stop the conduction of atrial fibrillation down the AV node so that it's slower, but atrial fibrillation can still persist on diltiazem. Some people have paroxysmal AFib and they're maintained on diltiazem, for just to control the heart rates and also regulate the heart rate. If that answers the question, or?
Yeah, I think so, yeah. One last one's kind of a big one. It's been in the news lately. It's about the iPhones and the effect the magnets on the newer iPhones have with defibrillators, pacemakers, things that are implanted.
Yeah, thank you for this question, Heidi. This is a great question. So as far as magnets and defibrillators, so the magnets and ICDs and pacemakers, big magnets do influence pacemakers and defibrillators. So small magnets like in the regular cell phones and all this don't have a big influence on these devices. High magnetic fields tend to interfere. Sometimes, people who weld, and have a generator there, which generates a big magnetic field, that could interfere with pacemakers and defibrillators and create something called EMI, which is called electromagnetic interference. What EMI is basically it trips the device into delivering therapies and behave abnormally. Now, with the new iPhone 12, they have a big magnet on the back of the iPhone, and just to have everything stick to it. But this has been shown, there has been an advisory that it does interfere. Having said this, if a person has an iPhone, just keep it far away from the device. Just don't put the magnet of the iPhone over the defibrillator.
Yes, keep those iPhones in the chest pocket, right? Is that the?
Yes, exactly.
Great. Okay, very good. I know we had several more questions. We thank you for your questions. Unfortunately, we will have to end at this time. But again, we want to let everybody know if you would like to review this topic with Dr. Chalhoub today, it will be on the Baystate Health website, probably sometime this week. All the ones from the previous weeks are also there for you to view and review or share with others. Dr. Chalhoub, thank you so much for sharing.
Thank you so much, today. Heidi. I just want to thank everyone. Thank you, Dr. Pak. Thank you, Dr. Kugomas. Thank you, Heidi, Andrew, Sue, anyone who was involved with these lecture series. I highly encourage everyone to watch them. Thank you so much, guys.
Great. Thank you. And we hope to see you all next year for Heart Month, everybody. Appreciate you coming.
Thank you. Bye.